Well, RJ, thank you very much for again inviting me to your cardiac tumor conference for Toronto. I'm sorry I'm not up there myself. I always enjoy coming up and visiting you. And I really admire you for continuing to push this forward. So this year, RJ asked me to talk a little bit about the general approach to non-primary tumors of the heart. And of course, they're much more common, but most of them are not something that we're going to deal with from my perspective surgically. Most of them are metastatic disease that are going to require systemic therapy. So I thought I'd just go over a couple of things that I see as a surgeon that I get involved with. Of course, the more common kind of widely metastatic disease is oncologic. So there are some metastatic tumors of the heart that I think are worth operating on, but this requires a very careful discussion with your oncology team and with your cardiology team to make sure you think you can really get this out. So this was actually a 72-year-old man who was 18 years after his primary nephrectomy for renal cell cancer. And he presented with chest pain and this large mass that was felt to be metastatic renal cell, but no tumors, no disease anywhere else. And to make it a little more interesting, he was the father-in-law of one of the cardiologists that was my largest referring cardiologist. So what do you do with a tumor like this, RJ?
Yeah, we need more information about what it looks like, but this is a metastatic lesion to the heart. It looks like quite a big tumor here. We'd have to see whether it's resectable or not. Nowadays, with the chemotherapy for renal cell, I'd ask them whether or not they could give some chemotherapy to shrink it down to make it a little bit more feasible for us to operate. Yeah, so if it's isolated to one spot in the heart, I think it's reasonable to take it out if it's resectable.
So whenever we see something like this, my first call is to my oncologist.
Yeah.
To find out what systemic therapy we have. This was 15 years ago, and my oncologist at MD Anderson said, "No, this guy's been pretty much maxed out in the olden days, and we don't think we can really do this." CT scan showed this on the surface of the heart involving one diagonal, and just kind of growing out of the surface of the heart, not really invading all the way through the LV wall. Normal LV, normal function otherwise. So we looked at this, RJ, and decided that, well, I thought this was resectable. We did resect this. We had to sacrifice one diagonal. And he actually did very well with this, went home, and he survived 6 more years when he presented with brain mets, and he died from brain mets. So, there are some metastatic disease that you can operate on, but again, they're few and far between. This was a man sent from MD Anderson that had an isolated mass in his heart that was felt to be melanoma. We spoke at length with the melanoma oncology service at MD Anderson, who sent him to us, saying, "Can't you treat this systemically with immunotherapy?" And they said, "No, we've blasted this guy. This is all we can do for him. He has no other disease. Will you operate on him?" And so we actually, this is a kind of a complex area to get to. So, once we made the decision, RJ, that we were going to go after this because the oncologist felt that if we could get a margin on this, he would do well. How would you approach this?
The isolated melanoma, as long as it's isolated melanoma, is resectable. It all depends, again, whether we feel that the heart, that we can resect the heart. I don't think you have to worry about the loss of ventricular function or loss of ventricular size, because these lesions tend to spread out the mass of the heart. And I think if it's something like this, it's quite reasonable. However, whenever you operate on something like this, you have to be concerned that adjacent structures that are not so adjacent, like the mitral valve, may need to come out as well. So you have to warn the people that they may get a lot more than they're bargaining for. And you as a surgeon have to be comfortable with knowing that when you go in there, you may have to do a lot more than you think you need to do.
Yeah.
But I think it's quite reasonable to ask your oncologist first, as you said. That's what we do as well. But as long as it's a single isolated spot, you don't want to get stuck with taking out one spot and the person coming back 3 months later with something in their brain or something like that.
So we were very comfortable. This was an isolated spot, but now it's down in the left ventricle. RJ, what are our options as surgeons to get down into the left ventricle?
The MRI will tell us how deep it is. I have resected tumors through the aortic valve, but those are really benign tumors. Malignant tumors, I'm worried that doing something like that's going to leave something behind. For those who don't know, we talk about R1, R0, and R2. R2 means you leave gross disease behind. You leave a bit of tumor there that you know is tumor. Uh, those patients will die before their sternotomy heals. They'll recur before their sternotomy heals. Not die, but recur. The R0 is where you think it's all there, and then the pathologists come back and say, oh, your margin was positive. That's not good. Your best option is to get an R0. In other words, get all of the tumor behind. So in this particular case, what we would do is we would go through a ventriculotomy in this particular case. We do have experience in ventricular aneurysm resection. And as a surgeon, you have to try to figure out what you've done in the past and how you can use your information and knowledge and experience and expertise from the past to deal with their problems you have now. So I would do this through a ventriculotomy and resect that tumor and whatever else has to come out. For instance, that may be a papillary muscle there. And hope that I get an R0 response. With a melanoma, it's pretty easy to see. With a sarcoma, it's harder to see. They tend to spread along the endocardium of the heart. And sometimes it takes a while for the pathology to come back, but if we have an opportunity to do that, it's okay. Fortunately, melanomas tend to be single spots, and what you see is what you get. And that's what I would plan to do for this patient.
So there are three ways we go after it. We can go through the aortic valve, like you said, and I've done that for benign tumors using actually a little thoracoscope to guide me. We can do a ventriculotomy. I'm not really keen on making holes in good muscle on the left side. The right side doesn't bother me. Or we can go through the mitral valve. The problem with going through the mitral valve with the heart in situ is that you have to go down and then back up again. So what we did was cut the heart out, put it in a bucket of ice, and flipped it over. And now I'm looking down at the mitral valve, and I could just push it out of the way. You could actually see the margins of this at the base of the papillary muscle. We got good margins. Pathology actually came back negative. And I lost track of this guy, RJ, at 5 years because he left MD Anderson, but at 5 years, he was tumor-free and doing well. So again, these are isolated cases, and you have to decide very carefully. They present interesting surgical challenges, and it's another reason why a global network makes sense, so that surgeons that are faced with this can call other surgeons and ask them, what have you done in the past? How does it work? And what might be easier to do? Now, it worked for us because I'm just pretty comfortable cutting the heart out and sewing it back in because I've done it about 58 times now, but it's not something most surgeons have in their repertoire.
And I have sent friends of mine who've called me up, or people who've called me up, especially from the United States, because they get my name, I send them down to you. And it's really important to have a friend that you can call, phone a friend.
Yeah. Well, next time, invite me and we'll come up and do it together in Toronto. Do it in the summertime, though. So the other thing that we see from time to time is stage 4 lung cancer that grows directly into the heart, but has no disease elsewhere. And so this was a 72-year-old patient who was actually in pretty good health. He had a tumor that was isolated to the lower lobe, but growing into the left atrium, and no tumor anywhere else. We got together with my oncology team and discussed this, and the answer from the oncology team was, if I could get margins around this, then a lobectomy and a left atrial resection would be the best thing for him. So, how do you approach this, RJ? You got this tumor, it's growing into the left atrium. You're unlikely to be able to just resect it without doing something to go on bypass, because you're going to have, you're not going to be able to clamp the left atrium. How would you approach getting this guy on bypass and doing this?
These are, of all of the tumors that we do that are more than just a tumor that passes through, these are the easiest to resect unless it's a sarcoma. We would go on bypass for this particular patient. We do it, unlike you do it, we do it all at the same sitting. I'm sure you're going to talk about that. We would do the pulmonary resection before going on bypass, before we heparinize. And after we have all of the dissection that we can in the lung, then we go on bypass and open up the left atrium and resect the left atrium, preserving or reconstructing the pulmonary veins if we need to that are distant from that. And these are the ones where I do get a resection margin, because if it's positive, and I've been burned with that with a sarcoma in the past, if it's positive, I will go back and resect more of the atrium if I need to. The best option again is to have an R0 resection, and that's the best opportunity to get that is in the first operation. So we would do that and either close it primarily if it's a small amount of myocardium that's affected, or if it's a larger amount of myocardium and you think you're going to remove a lot of the left atrium, to use a beast of bovine pericardium. It can be a little bit tricky, especially when you have to do a pneumonectomy, because the bovine pericardium is a non-compliant structure, and you can push up their left atrial pressure quite high if more of your left atrium is bovine pericardium than native left atrium. So my comment, if you're going to be doing this, not just you and I, because we have experience in it, but if you're going to be doing this as a surgeon, as a cardiac surgeon assisting a thoracic surgeon to do this, make sure you leave enough bovine pericardium there to allow a reasonable size of left atrium, especially if you're going to resect a lot of it, because you can run into pulmonary hypertension and problems with that.
I'd say, RJ, I rarely primarily close these because the left atrium is pretty easy to resect. And I take much more than I think I need and just patch it with bovine pericardium because there's little penalty to pay as long as you leave enough there. Now, RJ had mentioned doing this in 2 steps. Yes, we do that. We call it the Texas TwoStep. And we do that when I have to do a really complex cardiac resection, like an auto transplant or a very large resection and a pneumonectomy. And the reason we do that is that these complex, really, and this is not, I don't consider this complex. This is a pretty easy resection. And in this case, we're only doing a lobectomy. But if we're doing a pneumonectomy in a complex, then I worry about getting in coagulopathy and bleeding into that empty pneumonectomy space, which then requires transfusions, which then leads to more coagulopathy, which leads to more transfusion, which leads to unilateral pulmonary edema on the other side, which leads to death. And so we now will do, if we're going to do a pneumonectomy and a complex cardiac resection, we'll do the complex cardiac resection, disconnect the tumor from the lung from the heart, and then let them get over the pump run, and then come back the next day or the day after that and do a standard pneumonectomy, having already disconnected everything. And that actually works pretty well. In this case, RJ, what we did was just go on bypass. I take about half the atrium out here and just patch it with bovine pericardium. This was a lower lobe, so the whole lower lobe vein went. The upper lobe vein was still intact, and that's probably where I came closest to any tumor, was going as close to the upper lobe vein as I could get without compromising it. Going into the middle of the left atrium was fairly easy, and this patient did very well. This patient did develop metastatic disease 4 years down the line and died a year and a half after that. But otherwise, I think it's a pretty reasonable outcome for a stage 4 lung cancer, which are often just looked at and said, okay, this is non-small cell lung cancer. It's in the heart. We're going to treat you systemically, and that's it. My oncologist said, if you can get this out, this will really help our systemic treatment, which he got afterwards.
Now, Dr. DePro is going to speak to us later on about these stage 4 cancers, but I'm going to ask you a question. You take a large amount of left atrium, and again, it's to get an R0. Do you take biopsies of frozen sections at the margins or not?
I do on these, RJ, as opposed to sarcomas, because the amount of pump run that we have is not that long.
Right.
And so sitting there for 20 minutes is really not going to be harmful to the patient. But if you look at, and now what I do is I take as much as I can, and then I'm closing while I'm getting my margins back and hoping they're going to be negative. So far, I've been lucky and they've all been negative because I can take excess margin. But with sarcomas, you really can't do that. You just, you take what you can take, and that tends to be it because the pump runs are already too long. So yes, we do get margins acutely on these like we do with most of our oncology, but I don't just sit there and wait for margins. I'm closing while I'm waiting for the margins because I usually have a pretty good feel about where it is. Now, if it's really close to one thing like the pulmonary vein, I'll take a small piece right there and send that over and say, listen, I need this back right away.
Yeah, we do the same thing. And can you talk about how patchless you make your bovine pericardium? Have you run into the problems that I've seen with high PA pressure, high pulmonary pressures related to that?
No, I haven't. But I mean, my goal is to make it the same size as the original atrium. And I think that's one of the things. So certainly when I started doing auto transplants and taking out the posterior atrium, I initially left too much space between the 2 pulmonary vein cuffs, thinking there was more left atrium than there was. It really did okay, but it looked funny when I closed it. So I now try to look at how much I've taken out and make my patch match the piece I took out. Once you could lay it down there and add a couple millimeters around the rim just for sewing, that's how I do it.
And what about heparinization? Not heparinization, the warfarin afterwards.
I don't do that. I'm certainly worried about on the auto transplants that we do, RJ, where I've resected pretty much all the left atrium. It's essentially an AFib left atrium. We have not warfarinized those people, and we've yet to have any strokes. The good news is you don't have a lot of AFib either, because you've pretty much gotten rid of all the pulmonary vein connections. But I don't, that my N is not that high. So if you look at all the sarcomas, the number of auto transplants I've done is like 57 now. That's not a huge number to start figuring out if you need to be on warfarin or not.
So if you resect the whole left atrium and you have a completely replaced left atrium with pericardium, which is what we do when we do an auto transplant for the atrial tumors, you would not put that person on warfarin.
I haven't, RJ, but if some of my oncology friends look at some of these things like sarcomas as being hypercoagulable anyway, and they would like me to put them on just like 2 milligrams of Coumadin a day, just a very low level anticoagulation. I don't really have an objection to that. I just haven't done it routinely. And I certainly don't anticoagulate them to a 2.5 INR.
Okay. I'll change my practice.
Well, I wouldn't change because of me, because this is another reason why we need a database. So
yeah, that's right.
Study these things. Right now, most of us are doing this ad hoc based on what our own personal desires are. And our personal desires are usually based on our last disaster.
Yeah.
At least they are for me.
Yeah.
So this is an interesting patient that came to me. I'll skip ahead and show you this first. This patient came to me and was very short of breath and had a previous resection of a neuroendocrine tumor and had this tumor in the heart. So what do you do with a tumor like this? This patient literally couldn't speak a complete sentence to you.
So first I'd call you, but again, that's the reason to have the cardiac tumor database. So, I mean, what we need to do is we need to get a piece of this tissue to see what it is. This is within the heart. And, obviously you're showing us a CT scan for brevity, and I know you're going to get other imaging, including an echo. An echo is very, very important here to see what's actually happening in the atrium. These people, it'd be nice to give them some sort of systemic therapy first, if possible. That means if it's a lymphoma, give them a standard chemotherapy for that, et cetera, et cetera. So the first thing we would do with this particular patient is send them to the cardiologist, who would hopefully be able to get a piece of a tumor via the vein in the leg and get a small biopsy and send it to our pathologist to see if we can get a pathology. Sometimes the people are so short of breath that you unfortunately have to take into the operating room for treatment. And that would be hopefully an excisional biopsy, not an incisional biopsy, because the patient has compromise of the cardiovascular system.
So what RJ says about right-sided tumors being biopsied, we try to always, when possible, biopsy a right-sided tumor, particularly if we think it might be a sarcoma versus lymphoma. We've had several times where it's saved people from operations. The issue here was this guy was so sick, he wasn't going to do anything. We presumed it was going to be neuroendocrine because of his previous history. And I asked my first thing I do is go to my oncologist and say, if this is neuroendocrine, what can you do for it? And they said, nothing right now. If we're going to try to treat this guy, you've got to get rid of this tumor. So we actually operated on this guy. We took out his whole right atrium and part of his left atrium. We replaced the right atrium by taking a big piece of bovine pericardium, and I just kind of stapled it up each end, making a cava and an atrium, and just sew it from cava to cava and just patched it. And this guy actually did quite well, RJ, for 3.5 years. And in 3.5 years, he developed more widely metastatic disease and died. But he became completely asymptomatic and went back to a functional life. And then he could receive some systemic therapy. So, we can argue about whether or not 3.5 years of pretty much asymptomatic life is worth it. But if you ask this guy, he would tell you yes.
You bring a very, very important point, because I'm starting to do these at our hospital, and they see these giant resections of cancer and things like that. And they're saying, RJ, how long do these people live? We have people waiting for aortic stenosis and coronary bypass and this and that. when you're bringing a patient in and you're using OR time and ICU resources and the hospital resources and financial resources, it's a little bit different here in Canada than the States because there's only one wallet. When it dries up, nothing else happens. But we give them 2, 3 years, 4 years, 5 years. Is it really worth it? And last year, when we spoke about sarcomas, not last year, but before, the average lifespan of this particular patient is probably a week or 2 weeks if you don't do anything to them. And we have to have a different hat when we talk about people who have cancers that affect the heart, either secondarily or primarily. I think you have to compare them to other people who are in the same boat that don't have any treatment. And I think it's really quite worthwhile in these people. If we're giving them 2 months instead of, rather 4 months instead of 2 months, that may be something different at this point in time when we know more about them because we have a larger denominator. We may find things that may give them instead of 4 months, 4 years. And then if we have enough patients, instead of finding 4 years, we'll get 10 years. And so I think it's really important. That's a really, really important point that I'm asked all the time in my center.
Well, just remember when we started heart transplantation, they all died too. And now we do heart transplantation on a fairly routine basis. So here's another interesting case. This was a 28-year-old man who had osteosarcoma of the leg. It was metastatic to his right ventricle. He'd been treated very intensively over at MD Anderson. They had basically run out of what they could do. And the only disease he had was this disease in the right ventricle. This poor guy could not speak. He was so short of wind, he couldn't get out of bed. He couldn't move. And the folks at MD Anderson sent him over and said, what can you do? So what do you think, RJ? What are our options here?
Well, this is treated differently here than there. Obviously, you have, first of all, we would not transplant this patient. We have to be cancer-free for 5 years to do this. There seems to be that it moves around somewhere within the ventricle and is not stuck everywhere. And so the only option that I would have here, I would not do a Fontan type of a circulation in this patient. I would go in and try to see if I could resect it and leave no residual tumor behind. But if this person's close to death, which this probably is because of the large pericardial effusion, the patient has a lot of backwards pressure. It might buy him a short time, and the oncologist would be able to help him if it's all possible, but it's a real problem. So the only thing I can offer him is resection with hope that we get enough residual myocardium left that gives him some function so that the oncologist can get back to him and give him some treatment.
So RJ, I know you and I have both seen several people with large right ventricular tumors, and sometimes you actually can get in there and palliate them fairly well, and sometimes you can't. And it turns out in this young guy, I'll skip 2 ahead, this is what his heart looked like. This, you can see his right ventricle is completely growing into the wall. So I got in there and I realized there's just no way I was going to be able to take this out. So what I did was I took his heart out and I put in 2 thoratecs. And this was a long ago. The last time we've replaced hearts, we now use Syncardia hearts as a total heart. But he did really well with these 2 thoratecs. And he was a little over a month out. And we had him as at-home controller. And we were getting ready to send him home. And the plan was if he could live a year and a half with no evidence of disease, and of course we could use all the adriamycin we want to now because it's not going to hurt the thoratec, that we consider transplanting him. And I remember it was a Friday, and we were going to try to send him home on a Saturday because we thought it'd be easiest to move all this equipment on a Saturday. And I saw him on a Friday morning, and he said, I don't feel so well. When I talked to him, and I said, well, what's wrong? He said, I'm going to die. And when patients tell me they're going to die, that's a very worrisome thing. And so I called my device team, because I don't do devices anymore. It's a young man's game. And I said, there's something wrong with this guy. He says he's going to die. And they went and looked at him and said, well, you worry, Wart. He's just been a little bit over diuresed. We need to give him a little fluid. So they did. And I went back to see him at about 6 p.m. on my way out. And I said, how you doing? Better? And he goes, nope, I'm going to die. So I called my team again, and they said, listen, you're just an old worry wart. The next call I got was 2 a.m. He died. And what had happened was he was on Coumadin for his devices, and he bled into his chest. And we didn't think about tamponade because there was no heart in there, but he tamponaded his grafts. So, I think this is really at this far end of the spectrum of what we can do. But I mean, in institutions like mine, one of the things we're trying to do is figure out where's the edge of the envelope. And this poor fellow was doing absolutely great until he bled into his chest and died. I don't know, RJ, any comments?
Yeah, I agree with you that this is something that places places like yours who really are at the cutting edge of everything can explore. Even for places like mine at Toronto General Hospital, um, we would not go this far. I've the pathology specimen you showed is not surprising to me. That's what my pathology specimen showed, although I cut out the patient's tumor and left with tumor behind that one there, and leave it up to the oncologist to treat it. This is an extreme uh, case. It's unfortunate that he passed away, but again, it's a cutting edge, very, very cutting edge. And congratulations to you for even trying something like this. I'm always amazed when you talk about using a syncardia on somebody, but I'm always curious to see what the long-term results are for these people.
We do all these under an IRB protocol. We just don't do these ad hoc. And so
Yeah,
we've written a protocol about how we would do this, who we would do, and if anybody's interested in doing this kind of stuff, you really do need to sit down and put it on paper, do it with an IRB. You just can't do crazy, wild things. And these are all done under a lot of supervision. I mean, we didn't just come over one day and say, hey, let's take your heart out and see what we can do.
yeah. Yeah, the cardiac tumor, the cardiac transplantation for cardiac tumor has been discussed in the literature,
Yeah.
and the outcomes have not been uniformly very good. But unfortunately, as with everything else, the disease is so rare that the treatment is a very, very small number. So you lose one patient out of four, and all of a sudden you have a 25% mortality. People look at that very adversely.
So this is the kind of consult I get not infrequently. A 62-year-old woman who presented actually in Florida with the worsening cough, so they gave her a Z-Pak, hoping she'd get better. They added some antifungal treatment, never really got better, just got more short of breath and started choking. So she went into her local ER and got seen and then got imaged with this MR. So what do you think?
I think she's in trouble.
Yeah.
So this is a tumor again. That look at that. So I mean, here the considerations here are where's it coming from? Is it affect the esophagus? The esophagus is an area where I don't think we can do anything about. But this is something where, and if I were to be presented with a patient like this, I'd try to get a piece of tumor and hope that it's something that can be treated by their oncological colleagues and treat it as much as we can and see whether or not it shrinks down to a point where we can do something. And if we still can't do anything, I would send the patient for radiation.
Yeah. So I actually got a transbronchial biopsy, and it's sarcoma, intimal sarcoma of the lung, growing into the heart.
Yeah.
So I'm sorry, CT biopsy at the most, and so spindle cell sarcoma. So she's put on chemotherapy. The plan was to just keep following her along, and she's still in Florida. She gets a repeat imaging, and this is the repeat imaging. I don't know if this is actually.
Yeah, that's what you hope for. That's really good.
Yeah. So now it's a lot smaller, and it is confined to her lower lobe and her atrium. So what do you do with this?
Yeah, it's still a big tumor. I'd ask my thoracic colleagues. I'd still look at the esophagus to make sure it's not affecting the esophagus, and that can be done by esophageal ultrasound. They can give us a lot of information.
Yeah.
But I think that's quite reasonable if the patient's had enough chemotherapy that the oncologists are happy that they have given all that they can and it hasn't shrunken anymore and there's nothing else anywhere else. This would be a reasonable one to resect with a colleague.
So
thoracic surgeon.
Yeah, so the esophagus was normal on esophagoscopy, and I put a TVAR graft in where the tumor was, just in case I got into the aorta because I was planning on operating on this. Went in with my thoracic colleagues. They did a left lower lobe. We went on bypass, removed the atrium. The margins actually were negative on this lady. She recovered without any trouble, went back to Florida. The last I heard from her was 2 years later, she was doing well, and she had developed more metastatic disease and been put back on chemotherapy.
One of the things that I found is that when I've done a resection of the heart, big resection of the heart, they don't usually recur in the heart. They recur elsewhere.
Yeah, I think that's one thing that's actually really true, RJ. We used to have a lot of trouble with people recurring locally because of inadequate resection. So this is a young person, a young woman who's in her 40s, who is very short of wind, and this was a mediastinal paraganglioma. Now, I'm not showing all the imaging. You know, when we cath this lady, RJ, you could see huge feeding vessels like you and I always see. The problem was it was really pretty big. And so the question is what could we do for this lady? Because it's growing out of the mediastinum up into her posterior heart. So this is what we did. You can see it's pretty nasty looking, even for a virgin chest. So we're trying to get enough aorta out so we can cannulate the aorta. So we take it off the arch of the aorta. They took it off the atrium. And now we're on bypass, but we're not clamped. We're just trying to find where are the margins on the right ventricle. And you know, RJ, you've done a lot of these paragangliomas. You know, it's really pretty hard to figure out where they are sometimes. We've taken it off the ascending aorta. It came off the ascending aorta very well. Now we're going to cardioplege. We're going to cut the aorta in half and cut the pulmonary artery in half so I can get to the posterior mediastinal part of this. And you know, if you cut the superior vena cava, the aorta and pulmonary artery in half, you can really roll the heart way up and get to all of this stuff. So you can see it's a fairly large tumor. We're taking it right down to good ventricular muscle. And this will be my final case because they're going to make me go to the OR soon, RJ. So what do you think?
Wow, I would say wow. I mean, I'm worried about the esophagus there.
So we were too. So she's had esophagoscopy over at MD Anderson, and we see extrinsic compression, but nothing that shows actual invasion of the esophageal wall.
And then the other thing I'd be worried about is whether or not when we resect it, whether there's going to be 4 pulmonary veins that are going to be negative.
Yep.
So in other words, can we achieve a good result with that patient?
So this is the actual decision process that we're going through right now. We will talk about this lady RJ on Tumor Conference coming up next week, and you know, for those out there in the audience, this is how we go through this difficult decision-making process. Tom McGilvery, who's my partner, who's going to be taking over cardiac tumors as I retire and has been doing all these with me. He and I look at this and decide, first decide, do we think it might be resectable? And second of all, if it's resectable, how do we go at it? So the original diagnosis was intimal sarcoma. Bob Benjamin thinks this is probably not intimal sarcoma because it wouldn't still be here from 2015, number one. And number two, it seems too smooth for most intimal sarcomas. He thinks it's a liposarcoma now, something different, and a well-differentiated liposarcoma. In which case, if it really is, and we're lucky, a well-differentiated liposarcomas actually resect fairly easily. So I'm going to leave that, RJ, as my last case so that people get a flavor of what we get referred to us as we go through this as decision-making teams. I always like to end when I talk about tumors by thanking Dr. Cooley, who I did my cardiac training with. I got interested in tumors when I was a resident with Dr. Cooley, and I was running what was called his valve complex room as a second-year resident. And typically when you worked with Dr. Cooley, you would start the case and you'd send word, Dr. Cooley, do you want me to cannulate? And word would come back, cannulate or not, and it was always cannulate. And then once you had was cannulated, you'd send back word, Dr. Cooley, you want me to do the case? Are you coming? And if it was just some routine case, it was usually just go ahead and do the case, or otherwise he'd be coming. We had a young fellow that came to us from Italy, and he had a biopsy of a left atrial mass, and they just stopped. And they sent him to Dr. Cooley. And I sent out word, Dr. Cooley, do you want me to cannulate? And the word came back, no, which is really unusual. So he came in, he cannulated the aorta, the SVC, and low on the IVC. And then he cut the heart out and handed it to the nurse and said, now keep this, I'm going to want it back. And he didn't tell either one of us what we were doing. And we said, well, Dr. Cooley, where's the donor heart coming from? He goes, no, I'm going to put this one back in. And there was a big paraganglioma of the left atrial posterior wall, and he resected that and patched it with pericardium. But in those days, we were doing 40 hearts a day, and we kind of went through this fairly quickly. And unfortunately, this man bled, and his bleeding led to his demise. But it was clear to me that that the technical aspect of cutting out the heart, replacing the tumor, if we just did it a little bit better, would work. And that's what launched me back in 1984 on this long-term quest to figure out heart tumors. So thank you, Dr. Cooley. RJ, thank you for having me at your conference. And I apologize. I've unfortunately got a full schedule today. I hope next time I'm in Toronto and then I can't run away.
Yeah, thank you very much, Michael, for your friendship and your mentorship and thinking of this whole thing. You really are the father of cardiac tumors in the world, and I'm happy to call you a friend and a colleague. One of the questions that was raised here is that they biopsy, and Dr. Regala can talk to us a little bit more about this in the future. They biopsy the neuroendocrine tumors in the abdomen, and what makes it different in the heart. Why don't they bleed to death in the retroperitoneum, and why do they bleed to death here? You want to take that one?
Well, I think it's because they all have these giant feeding vessels off the coronaries. And so, we see these things in the belly. We see the paragangliomas up in the neck too, where we embolize them. I don't embolize my cardiac paragangliomas yet. I don't know if that would help or not. I just don't. But the ones that are up around the heart, as you know, RJ, if you take a picture of them, they have huge, huge feeding vessels. And, I guess if you're lucky and you missed all those, they might do okay. But I've had 2 people that were biopsied by needles and almost bled to death and then sent to me in Houston. So that's not a huge N, but it's enough of an N for me to say it's probably not a good idea.
The other thing is that it's in an open pericardium.
Yeah.
So they can get a tamponade, whereas they can bleed into the retroperitoneum and get a hematoma, but hopefully it'll be self-limiting, I think.
Well, both of these were biopsied. They got tamponade, they got operated on, got nothing but the hole sewed up and then sent down to me. It would have been a lot nicer if they were just sent right down.
Yeah. So we say the same thing. Patrick, if I know it's a paraganglionoma, I won't send it to you.
Yeah. You really don't want to do that. And I really apologize. I really would love to hear the percutaneous biopsy. We think that's crucially important. We biopsy all right-sided ones that we can, that don't have we don't have to do something else with. And quite frankly, I would love to biopsy all the left-sided ones, but the concept of a transseptal biopsy is a little more daunting than just doing a right-sided biopsy. So thank you, guys. I apologize, RJ.
Thank you very much, Michael.
Save and human misery to relieve in Houston, so I got to go.
I want to put a plug out for your cardiac tumor board meeting, Michael. If there are people around the world that want to join it, they can contact me and you or you specifically to contact it. If they can't get a hold of you, contact me. It's a very, very important tumor board that you have, and it really is a world. And so it's very important.
It's a great learning experience for people that are interested or want to start their own program.
Yeah.
Thank you, guys. Bye.
Thank you.